Hello, everyone. So let's quickly revise the latest bronchiectasis guidelines that were published in ERS in August 2025. So let's start with the vicious vortex or the Colles hypothesis, pathophysiology of bronchiectasis, which starts with inflammation due to some trigger, followed by infection, and then impaired mucociliary clearance, mucus hypersecretion, further promoting lung damage, and again completing the cycle by promoting again inflammation. So they have given this cycle, this vicious vortex in the latest guidelines. So here you can see the green tick. So the green indicates that the treatment which has received a recommendation in favor. And the two green ticks tell you that it is strong recommendation, whereas one green tick tells you conditional recommendation. The red tick indicates against the receiver recommendation against. And then further, you can see these circles which tell you the number of plus tells you the certainty of evidence which is available. So at the level of inflammation, you have long-term macrolides. There is as such no role of inhaled corticosteroids. It has to be given only if there is asthma and COPD along. Similarly, in infection, you can give long-term antibiotics, inhaled antibiotics, uh, with Pseudomonas aeruginosa, without Pseudomonas aeruginosa, even for the eradication. But as such, they have removed the efficacy of long-term non-macrolide oral antibiotic at this stage. Then impaired mucociliary clearance, of course, ACT, mucoactive drugs. Then there is no role of recombinant DNAs. Then coming to the lung damage. So pulmonary rehab is the one which affects the most. Coming to the next. So the first question that was there in the guidelines was a narrative question that how can underlying causes of bronchiectasis be identified and how can the severity, comorbidities and other treatable traits be evaluated. So then there are few tests which has to be done in all the patients of bronchiectasis and few tests they have certain indication. So all tests which have to be done in patients of bronchiectasis to identify the cause and the etiology is immunodeficiency screening, including IgG, IgM, IgA, the whole ABPA profile, including eosinophils, NTM, either in microscopy or culture. Also assess for comorbidities and treat them accordingly in all the patients, whether it is cardiovascular, GERD, osteoporosis, anxiety, depression, or rhinosinusitis. One thing that we are not doing is BSI. So do calculate BSI, bronchiectasis severity index, in all the patient to assess the risk of future complications. So BSI, as everyone know, it is an extended version of FACED score. So FACED में F stands for FEV1, A stands for the age, C stands for the colonization, E stands for extension on the X-ray, whether one lobe is involved or more than one are involved, and D stands for dyspnea, that is MMRC. So BSI includes two, three more components, like it includes the number of exacerbation in the past, number of hospitalization in the past, and colonization due to non-Pseudomonas organism. Then a few selective tests like alpha-1 antitrypsin testing, it should be done if the clinical and radiological features they are suggestive of the deficiency like basal emphysema or severe airflow obstruction. Similarly, cystic fibrosis and primary ciliary dyskinesia if the patient is having symptoms onset since childhood and there are specific clinical and radiological features. Then these guidelines, they have very clearly classified high risk groups. So this include patients with the COPD, primary ciliary dyskinesia and RA associated bronchiectasis, patients with the Pseudomonas or any other gram-negative infection. Then patient with more than equal to 2 exacerbation per year or even more than one severe exacerbation leading to IV antibiotic use or requiring hospitalization in the last year. Then patients with the severe symptoms, of course, requiring the fit criteria of high volume of daily sputum production, sputum purullencies, then of course NTM and ABPA. So these latest guidelines, they say that at every visit, not just at the diagnosis, at every visit, you have to evaluate the patient for underlying cause, comorbidities, disease activity, as well as check them for treatable traits. Then this is one of the table which includes investigation and management consideration for the initial assessment and then subsequent etiological testing for adults with the bronchiectasis. So these are the baseline investigation, which include CBC, serum electrophoresis, ABPA workup, immunoglobulins, and NTM. After ruling out this, then you look for the radiology. If it is upper lobe predominant, check for cystic fibrosis. If it is middle lobe and lower lobe bronchiectasis, associated situs inversus, male infertility, check for PCD. Localized bronchiectasis, check for NTM. Systemic symptoms, check for autoimmune diseases, coexisting emphysema associated with COPD, familial history positive liver disease, check for alpha 1 antitrypsin. And of course, if there are recurrent infections, pulmonary as well as extrapulmonary, check for immunodeficiencies. Then, what's the latest comment on airway clearance technique? So in 2017, they recommended it mainly for the patients with a chronic productive cough. But these latest guidelines, they have a strong recommendation for all the bronchiectasis patients. It includes patients with a dry cough and mucus plugging on HRCT, even during exacerbation also. A physiotherapist-led training. So this is the major conceptual shift that airway clearance technique. These airway clearance technique we'll discuss in one of the future lecture. It is the core therapy and not an optional therapy. Coming to the mucoactive drugs, the earlier guidelines, they say some mixed reactions and unclear, but now they say that you have to use them if the first thing, that is airway clearance, fails. And you can use carbocysteine, erdocysteine, but then recombinant DNase is still not recommended. Coming to the long-term inhaled antibiotics. So now they say a strong recommendation for this in the patients who have a Pseudomonas aeruginosa chronic infection along with a high exacerbation risk. Conditional recommendation for non-Pseudomonas species. So now the high risk is clearly defined as patient with a history of more than equal to 2 exacerbation in the prior year or more than equal to 1 severe exacerbation or even 1 exacerbation plus severe daily symptoms. The defined duration or the trial period when you can say that these inhaled antibiotics are actually working or not is 3 to 12 months. So minimum of 3 months, but then most of the available data in the literature have worked upon 12 months. So clinician would reevaluate the efficacy after 1 year, and in the view of antibiotic stewardship, if this is not actually working, you'll stop it. And they say to supervise the test dose because there is a risk of bronchospasm. So you can give Duolin or some salbutamol along with these inhaled antibiotics. Then long-term macrolides, again a strong recommendation. So all the patient, irrespective of they have Pseudomonas risk factors, Pseudomonas status, irrespective of whether they have or not airway infection, but they are at high risk of exacerbation, they should get macrolides. But before starting macrolides, do check for NTM. Rule out NTM. Azithromycin dosing has been clearly standardized as either 250 mg 3 times per week or 500 mg 3 times per week. Always check for the surveillance ADRs like ECG, hearing side effects, and GIT side effects. Coming to long-term non-macrolide oral antibiotics like amoxicillin and all. So they don't say that never use them as the first line agent. So reserve only if macrolides are actually not working and they are contraindicated. So this is one of the table which has been given in the guidelines. It says that you optimize the bronchiectasis management. Always ACT is the first thing. Treat the comorbidities, check for the treatable trait, still at exacerbation high risk, check for Pseudomonas aeruginosa infection. If it's there, go for long-term macrolides or long-term inhaled antibiotics. Even if it is no, so irrespective of this, long-term macrolide is the first treatment of choice. If the patient, then you have to reevaluate at 12 months. If the patient is responding, of course, you can continue with the same treatment. If not, you can switch the treatment to either inhaled or oral non-macrolide antibiotics. So now, should eradication treatment be used for patients with the isolation of a new pathogenic microorganism? So the latest guidelines, they basically clarifies now what constitutes new isolation. So any new appearance or some new organism which was initially Pseudomonas, but now the sputum or bowel culture is going some new organism. So there is a heterogeneity in practice, of course. So the antibiotic regimen remains the same as were in 2017, that is 2 weeks of oral or IV antibiotic, followed by 6 weeks to 3 months of inhaled antibiotics. This depend upon clinician to clinician, but then patient undergoing eradication treatment should have their cultures, sputum cultures performed after the completion of therapy and at least at 1 year to confirm that eradication was successful. If the eradication is not successful, then you can label the patient or you can treat the patient as chronic Pseudomonas aeruginosa infection. What's the status of long-term inhaled steroids as we discussed in the earlier slides? So, not to be used, only to be used if there is coexisting asthma or there is a COPD along with an indication. A single rise in eosinophils is not an indication actually. Rehab, of course, strong recommendation. Then, so what are the diagnostic tests or the intervention that are recommended for managing exacerbation? So one should know the definition of exacerbation, which is defined as worsening of symptoms and which exceeds day-to-day variability and requires a change in management. Core symptoms, everyone know, change in the cough, increase in sputum volume, sputum purulency, sputum consistency, increase in dyspnea, exercise intolerance. Systemic features like fever, anorexia, weight loss can also be there. So, features of a severe exacerbation. Severe exacerbation is defined as the one which requires hospitalization or IV antibiotics. So they can have now tachypnea, acute and chronic respiratory failure, decrease in saturation, hypercapnia, hemopsis, cyanosis, corpi. So they have given the criteria for defining an exacerbation, simple exacerbation, and a severe exacerbation. So of course, when a patient come to the emergency or even in the OPD with the exacerbation, you have to send the sputum sample before initiating any antibiotic. So antibiotics can be given on the basis of the last microbiology results or the local susceptibility patterns. Of course, you have to tell the airway clearance regimens. You have to tell them a 14-day antibiotic course is ideally needed if a patient you are suspecting or grows Pseudomonas aeruginosa. Shorter courses may be given if patient has just mild bronchiectasis and infection due to pathogens which are more sensitive to antibiotics like Streptococcus pneumonia infection. So the last, the investigation and the treatment which are currently recommended in a patient who is rapidly deteriorating in terms of symptoms or exacerbation. So this is a rapid uh, thing which they have given in the guidelines where R stands for recognize and refer. So you recognize that this patient is rapidly deteriorating even despite giving the treatment at your best. So you refer the patient to some bronchiectasis specialist. A is for assess the patient's history, examination, check for ACT adherence, check for some new developed or some worsened comorbidities and the presence of treatable traits. P stands for perform. So you basically advise the patient to go and meet a physiotherapist and get checked your ACT thing. Then an HRCT chest, sputum cultures to rule out all the infection, TB, bacteria, fungi. Bronchoscopy, if patient is not providing sputum. Test to reassess for ABPA or any other underlying cause, and of course, a full PFT. I stands for initiate, so you start antibiotic treatment for the infection, eradication therapy for Pseudomonas when appropriate. If you find NTM or any fungal lung infection, treat accordingly. So basically, organism specific treatment has to be given. And if organism, all the infections are ruled out, then you just give the etiology basis. And ACT has to be given in all the patients. Then, if infection is eradicated, you have to advise the patient for the long-term maintenance therapy. And last, D is stands for deal with complication, which is if patient is malnourished, refer to dietitian. If patient is having hemoptysis, sent to some interventional radiologist for bronchial artery embolization or surgical resection. If still patient is having high burden infection which is not responding to antibiotics, patient is having respiratory failure. So of course the last resort is NIV, supplemental oxygen and referral to a lung transplantation center. So this was all about the ERS 2025 bronchiectasis guidelines, which basically transform bronchiectasis from a supportive care disease to a structured, proactive, treatable, trait-driven condition with the stronger core therapies. So if you like the presentation, please share and subscribe. Thank you.